Good afternoon and welcome to the Independent Scientific Advocacy Group public meeting. ISAG is a group of scientists, medics and others who are interested in an evidence-based approach to pandemic management. And today we are going to talk about how vaccines plus some other things can help us in our pandemic management to get out of lockdown and stay out in a stable way. And it's been an interesting week. As we have seen in the UK, they've had to delay some of their reopening plans because they didn't take certain early preventative measures in terms of preventing the entry and spread of the Delta variant. And in Ireland, we have the privilege of being able to see what's happening there and to perhaps take some evasive action here and avoid similar situation. And so we're going to be talking about this and other things today, about what the Delta variant is, what it means for the UK, and we can try and translate some of that to Ireland as well. So I'll be talking with Dr. Gabriel Scally very shortly, but before then, we have our situation update from James Merrick. Thank you, James.
Thank you. Thank you very much, Aoife. Agus Diagweev Accordia. So the kind of high-level summary before we go into the slides is that in Northern Ireland, after this long sort of slow, steady decline, we were noting in previous weeks, we're seeing an increase in cases again. And then in the Republic, data is still limited by the HSE cyber attack, but we're able to kind of piece together some broad trends that have been pretty good this week or the past 10 days or so. So well, and then we'll talk a little bit about the international context too. So yeah, great. So we'll start with Northern Ireland. If we can just bring up the first slide, please, Ben. And yeah, so when we get there, yeah, great. So. And thanks as always to the kind of data team in the background here who helped piece together the data. So if we bring the next slide, please, Ben, and we'll start with Northern Ireland. And as I said, the black line here is the population average, and we in previous weeks, regular viewers of the webinar here would hear me say, okay, it's kind of the same as last week with a little decline, but that's like the left-hand side of the chart here. But if you look at the right-hand side, we see this increase to the right. The black line is the population average, and this again is daily average cases per 100,000. So it's driven by younger age groups. The orange line at the top there is 20 to 39-year-olds, blue line 0 to 19-year-olds, and even the green line there's an uptick of 40 to 59. So the story here is, I suppose, vaccination in the older age groups. The Delta variant is probably part of the story, but probably a big part of the story is this uptick, this change of trajectory started about 5 days after the reopening of indoor hospitality in Northern Ireland. And so, yeah, so we all know about, at this point in the pandemic, about indoor spaces and the dangers therein. So if we can go to the next slide, please, Ben, and so we're going to return to Northern Ireland, United Kingdom, in a couple of slides more, but first I want to go to the Republic. So as I said, the cyber attack, our usual data sources with the HSE are missing, but we can the daily case numbers are released every day with an asterisk beside them, subject to verification, but kind of piece together a trend here. And this chart here is the just the daily cases, raw absolute numbers, not population weighted, and starting around Easter week. At that time in Easter, people might recall we had a decline, then, kind of a period after schools reopened, we had a jump again, and we had this sort of oscillating around 400 cases, 450 cases a day. But in the past week, 10 days, we've seen a decline down to this 300 cases a day level. So that's, good news. A lot's happened. More things have reopened, but more outdoor things. And also, I don't know, maybe hundreds of thousands of people in secondary schools are not gathering in secondary schools anymore as of the end of May. So that's, like all these things, correlation is not causation, but given what we know about the indoor spaces again, it's a trend. And the other important thing to say about this number is it's probably to outdoor dining and outdoor hospitality. It's opened Monday, Bank Holiday Monday, so it's too early to say at this point it's too early for those to show up in the cases and a kind of rolling 7-day average here. So we'll await how that goes over the coming days. If we go to the next slide, please, Ben. Yeah. So the age. So this is from the 3rd of June, so almost 2 weeks ago. But this was just a snapshot of the age distribution that day, just to give a sense of the sort of. We don't have our usual age data, but basically we can see that the majority of the cases are in. Vast majority of cases are in 44 and younger, but probably still a majority in 24 and under. So that's this concentration of cases in that group. That's where most of the circulation is occurring, and it's also the group furthest away from vaccination. But obviously, it's good news that there's such a drop off and small numbers in the older age groups. If we go to the next slide, please, Ben. And I know we're going to be talking a bit more about vaccinations later in the webinar, but just some of the numbers here may be relevant in relation to the previous slide. I just pulled this as a Realtas na hÉireann slide from yesterday, but there's probably two numbers there. 56% of the adult population have received at least one dose, and a quarter have received are fully vaccinated. Registration opening soon for those under 40. We'll be talking about the Delta variant and the kind of importance of being fully vaccinated in the context of that variant, and just that mismatch between who's vaccinated and where the cases are at the moment. So just again, context for our talk today. And then next slide, please, Ben. So following a few weeks break, we have a bit to catch up in our update. So try not to take too long. But the next slide is just the United Kingdom, and it's just to show our trends here. So there's just a sharp increase in Wales, England, and Scotland. And Northern Ireland, this increase we previously talked about, not quite as sharp. Underlying the England data, there's some interesting things like Bolton. Bolton had this kind of first wave of the Delta variant, and it's actually peaked, while big cities like Manchester and Liverpool are on this exponential growth. But also in Bolton, stories of empty restaurants and kind of declining economic activity, which kind of going back to our economics discussions in previous weeks about, a kind of a rampant virus does more damage or as much damage than any set of restrictions, and people respond accordingly when they see these things happening in their communities. So going forward, traffic between the two islands and just the trends, this trend happening, given the low numbers in England and Scotland up to a few weeks ago. And this was all well outlined by Professor Pagel in our previous webinar. The next slide, please, Ben. I want to give a little more context about our neighbours again. This is European Union, so I suppose this trend has European Union total cases, so that has been able to follow a steady decline. And of course, there's various news stories about countries trying to keep the Delta variant out. Yeah, so that's just a broader context. And then the final slide is just a world context, and this is since the start of the pandemic, daily confirmed cases. There's a lot of international stories that are probably very relevant for us, and how to put them all on one slide, but I said I just put this international context, and this big drop we've had in recent weeks, there's a little bit of tapering the past couple of days in the average number of cases, but the big drop has been driven by the drop in India. But this drop in India has been a terrible cost. Again, we've had self-imposed, people seeing the funeral pyres and kind of locking themselves down and this drop in economic activity in India. And kind of, this past week there was particular reports from certain Indian states about the incredible number of underreported deaths during the wave. Really incredible numbers. But three other points I wanted to make internationally was there was a report in the past couple of weeks from Reuters about 32 members of the Congo Parliament have passed away from COVID at this point. So these are not picked up. If you look at Congo's case numbers, they're not there. But obviously there's a lot of spread. And then the last 2 points on the international context. So Paul Dempsey, who regular viewers will know, Paul has been concerned about a recent uptick in cases and deaths in South Africa, and I've learned to view Paul's warnings. I've learned the past year have, 6 weeks later, I go back to Paul and say, "Oh wow, you caught that." So that's something Paul has been highlighting to us recently. And why does South Africa matter is because the variant there has had greater vaccine escape properties than some of the other variants. And the last point internationally, kind of underlying all this kind of big global number, is the case of Chile, where the death rate is still quite high, despite 70% of the population having received the first dose, an increasing number second dose, and that's with a mixture of vaccines, including Chinese vaccines. So I suppose that the sort of vaccines plus theme, I think Chile is a good example. So that's the context. It's a real mixed bag of good. I think it's a real mixed bag of good and bad news around the world. So, and locally and internationally. So that's where we are. So thanks for your time.
Yeah, thanks, James. Yeah, there is some good and some bad news among that. So of course we should take great encouragement from the fact that the numbers are going in the right direction here. And Europe on average is also going in the right direction. But yeah, I think we have to take note of what's happening in the UK, especially England and Scotland, and pay attention to that, because we don't want to be in that situation. We have plans for the summer as well, plans for a domestic summer and various amounts of reopening, which can give people some, I think, much needed relief and relaxation. And I think we ought to pay attention to the fact that that's something that needs to be safeguarded and protected. These things don't just happen automatically. And as you see from the international picture, this isn't over yet. So thanks, James. That's really useful as always. So now I'm going to hand over to Gabriel Scally, or have a conversation with Gabriel Scally, and I think he's well known to everybody at this point. Gabriel not only is a regular member of these meetings, but he's also a member of Independent SAGE in the UK. And so as in that context has a lot of extra insight and information. And we are lucky that the UK has such good genomic surveillance. So this means that they recognize when a new variant is there. They can collect the kind of information that allows us know that something is a variant of concern. And we've benefited from this multiple times. We haven't always heeded the warnings, but they identified the B117, now known as the Alpha variant, and they have been for weeks and weeks now telling us that this Delta variant is concerning, and that even with their rates of vaccination, which are ahead of ours, that it isn't plain sailing, that they are not yet at sufficient vaccination coverage that they can just say that everything can proceed as normal. And as we saw this week, they had to delay part of their reopening. So, Gabriel, I'm delighted you can join today and tell us a bit more about this, because I think it's going to be really useful for us to hear more about this. So maybe you could start off with something like the current position in the UK with the Delta variant.
Indeed, and for most of the UK, the Delta variant is the only game in town. It's been one of the fascinating things over the last number of weeks, has seen this new, very transmissible, very dangerous variant really outcompete what was what is the Alpha variant, but which was the dominant one, the one that was first identified in Kent. And it's just been amazing to see that competition going on, and the Delta variant coming out streets ahead, and the Kent variant really disappearing off the scene. And in some ways, it has looked very stable while that transition has taken place. But now with a dominant Delta variant, certainly in England and increasingly across the UK, that position is really changing fast, and it's hard to It's hard to capture that, and it's hard to explain it because the number of cases is still relatively small when you think of the huge numbers we had. But the growth is really amazingly high. In the last 7 days, for example, the number of cases has gone up 39%. So that's up to 54,000 cases, which is in that 7-day period. Again, small compared to what we had, but it's still a growth rate that's really, really worrying. And that has fed through then into hospital admissions. Of course, it took some weeks for that to happen and for the data to emerge. And some commentators were saying, oh, it doesn't matter. It's not going to have an effect, but it is having an effect. And hospital admissions gone up 22% in the last 7 days. So that's over 1,000 people admitted to hospital in the last week. And it now looks that for every 100 cases we have, and this appears to be relatively stable at the moment, for every 100 cases positives we have, that's resulting in 4 admissions after a period of 10 days. So that's the sort of shorthand that people are looking at to try and model what's going to happen. I think the interesting thing as well, of course, is that as ever, these cases are not spread evenly. The UK has had long-term interest in health inequalities. So it is looked at all the time, particularly by the scientists. The government doesn't pay as much attention to it and hasn't done for the last 10 years, really, inequalities. But the inequalities are there in spades, with the northwest region of England having by far the highest level of cases per head of population. It's 5 to 6 times higher than the east of England or the southwest where I am. So that's a huge difference. And that's not a surprise, because that's the position we were in kind of this time last year when we were talking about easing off that first set of really severe restrictions. And we now know, when we came out of that it was highly problematical still, the virus, in quite a few places. And there were local authority areas in the northwest, in the Greater Manchester area in particular, where the virus was still endemic. But because the national picture looked all right, the decision was made to relax things. And then it led to a resurgence. And the characteristics of those places tended to be, at that time, the local authorities where it was spreading most, had 3 very notable characteristics. One was a high level of deprivation, and there's very clear indices that map deprivation in England. And high level of deprivation, a high proportion of overcrowded housing, and again, as you could imagine, with something as transmissible as this coronavirus, that makes a big difference. And knowing the level of overcrowded housing is a really good indicator of where you're liable to find problems, particularly if that is multi-generational household, because of the different vulnerabilities of people of different ages. And that ties sometimes also to the third factor, which is a high proportion of the population from Black and minority ethnic communities. So those 3 factors together explain a lot of that variation. And of course, it is absolutely tragic for some of these local communities, because places like Bolton or Blackburn, or indeed, I know Leicester's in the Midlands, but Leicester's had a terrible time as well. And some of them have been under restriction, either local or national restriction, for such a long time now. And it is really having a tremendous effect, because, of course, these are the poorest people in the country that we're talking about here. So there is that huge difference in the spread. I think those 3 factors are still very prevalent. So the current situation isn't good.
Yeah, and it's important point you make that the numbers on the face of them might look still small, but now is the time to act. I think we've had the mistake, I think, a few times over the last year of waiting until it was time to panic and having to have, a big emergency reaction to a really, really bad situation. Whereas we ought to know by now, we ought to be learning as a general public that exponential growth looks it looks a bit more innocuous at the beginning. The numbers do start small, but very, very quickly they get really, really high. And it's so much easier. Prevention is so much better than cure in this case, because if we let the cases get very high, then we're talking about drastic situations, and we're talking about having to, have really severe restrictions again, which of course nobody has an appetite for. And so it's so important that so in the UK, but also here, that we don't let this happen again. That we pay attention. So where you're talking about these regional differences, you mentioned quite a few factors, and the deprivation and the housing conditions. Of course, we see the same thing here. Where you have people in crowded housing, of course, you get really bad transmission, and it correlates with working standards and a lot of these things as well. So we're seeing the same pattern everywhere. But what about the vaccination status and the vaccination rates in the UK? So we've been hearing that, the vaccines are great, the vaccines work, but you need your 2 doses. So you're ahead of us in the UK. So what's the situation there?
Well, the situation is, of course, that vaccination has been very successful. One of the reasons it's been very successful is being rolled out by the NHS. And we're at a very high proportion of the population is now vaccinated with at least 1 dose. I think one of the things that the Delta variant has done is it's changed some of the thinking. And it's a very fleet of foot approach, of course. The UK took the decision to proceed as quickly as possible to get as many first doses into people as possible, and extended the time period to the second dose up to 12 weeks. And that had a fantastic effect. It really saw plummeting case rates, and in my mind was the perfectly correct thing to do. What we now know from the Delta variant is that 1 dose isn't enough. Really, you do need 2 doses. So they're shortening that gap now, and people are bringing forward their planned vaccination date. And it's been opened up now in some parts of the UK to over 18s to book their slots, and people are able to move their slots and try and get that gap reduced. So it is doing very well. Pause and then but. And the but is that that variation that we were just talking about, Aoife, the variation driven by these social inequalities is playing out in spades in the vaccination when you look at the data. So the data shows that there are several characteristics which would indicate a lower uptake of vaccination. Some of them are, in fact, none of them are surprising, but we need to be paying a lot of attention to that. And they are things like, interestingly, some things don't have much of an effect. Educational status doesn't seem to have much of an effect. Housing tenure has a very substantial effect. So people who are living in private rented accommodation have the lowest uptake of in terms of their housing tenure. People who don't speak English have a very low uptake. People who have never worked or are in long-term unemployment have a low uptake. And there's a very substantial difference in uptake between different ethnic groups in the population, with some minority ethnic groups having a really low uptake. Now, a bit like what we were talking about Greater Manchester and some of those local authorities, those factors coming together, and you can see how those factors will come together. And as a public health physician, I look at a really successful vaccination program, and then I worry about the people who are left behind because of the granularity of the vaccination response. I know from my own experience, of course, we've never had to do a program this big, but I know from running programs that it's pretty easy to get the majority of people, at maybe up to 70 or 80% vaccinated of your target audience. But it's really difficult then to get that up over 90% and into the high 90s, the sort of levels we need to deal with measles, for example. That's really tough, and it requires really good local action. And across the UK, we are lucky in having local public health teams, but in particular in England, those local directors of public health and their local public health teams haven't been properly resourced and haven't been given a way forward. And of course, Northern Ireland is the only part of Britain and Ireland that doesn't have local directors of public health or local public health teams. So that's a particular problem, I think, in getting that vaccination out. In terms of its overall effectiveness, there's no doubt about it that the vaccines still remain effective against this new variant, but with some nuances. And I mentioned that about 2 doses being really significantly better. And the modelling that's going on at the moment think that the risk of an infection, and when people talk about how effective they are, they need to specify, and you hear different percentages, and that's because people are often talking about different things. And when the media pick up on someone's release of their data, the media doesn't go through, doesn't do nuance. They just give you a figure, it's X% effective, but they don't say in doing what, and they don't say that it's only at that level after 2 doses, and then they don't give the details. So, and you often find people talking about different things. So there's a level of protection against getting the infection, which is really important, of course, and that's pretty high. And the current modelling that's being used across the groups doing the modelling for the government believe that after 2 doses, the reduction in infection is for AstraZeneca between 55% and 71%, and for Pfizer 73 to 85%, which is pretty good. Then the next layer of that is the risk of passing it on if you do get infected. And after 2 doses, the risk of passing it on, according to the modelers, for AstraZeneca is somewhere between 33 and 45%, and Pfizer 33 and 56%. Again, another significant slice of protected people there, but also still some transmission. The risk of hospital admission, which seems to be one of our key concerns at the present time, because we do worry about a big surge in hospital admissions. The modelers are saying that the current 2-dose of AstraZeneca will produce a reduction of 85 to 90%, and Pfizer 89 to 91%. And then, of course, the risk of death is reduced very substantially, and the estimates for that are into the 90%. It depends. When people say, ask you how effective a vaccine is, well, it depends what you're talking about.
Yeah. And is that for the Delta variant? Do they have that level of information collected now?
That's all. Everything now is geared absolutely to the Delta variant, because that's what's driving.
That's really good, it's just really, and it's so encouraging. I mean, I think that's why we're talking about like the vaccines and vaccines plus. So we are so lucky, really, and it's so great that we have such effective vaccines for this virus in really such a short amount of time. I often remark that. Yeah, and who would have thought, 15 months ago when we were just starting to learn about this whole thing, or just a bit before, that getting multiple extremely effective vaccines would look like the easy part, because that sounded like should be the hard thing, but it seems like getting good policy from the government seems to be the hard part, frankly. Because we have these really good vaccines.
But there is a problem. One of the issues is we mustn't squander this fantastic achievement of getting these vaccines. So we must make maximum use of the vaccines, and we can only do that by having a proper integrated approach to curbing this virus. Vaccines by themselves will not do it. And James kind of hinted at it when he was talking about South Africa. The real fear lurking in the background is that we won't get the virus sufficiently under control, that to safeguard ourselves from a new variant popping up that maybe combines some of the features we've seen in the variants. We've seen particularly this Delta variant that it's much more transmissible, maybe 50, 60% more transmissible. Even outdoors, it's substantially more transmissible. And then if you added that into the ability to dodge the immunity from vaccination of the South African variant against some of in respect to some of the vaccines. And if the virus is clever enough to put those two things together, then we would be in real difficulty across the world. And we need to remember we've got maybe 2 years, unless the world, wakes up and lifts the patent, changes the patent laws to allow people to produce vaccine on a mass scale, we've got maybe 2 years to go before we can say that this vaccine is, really driven down across the world. And that's plenty of time for it all to go wrong again. And the thing is not just vaccination and then it's all done and dusted. No, it can't be that. We need to put in place the kind of systems to keep us safe. And that's why some of the discussions at the moment are really, really important. And in the UK, things are turning to travel restriction. And there has been, extremely widespread criticism of Boris Johnson's lack of decision-making. His vacillation around stopping flights arriving from India and not having adequate quarantine arrangements in place. And that's been across the political spectrum. There's been criticism of him for that, which I think that criticism is quite correct. And then there are real debates taking place. The headlines today in many of the newspapers are about the government is kite flying about compulsory vaccination for all NHS staff and all care home staff. And for the NHS, that is huge. The NHS does insist on compulsory vaccination for hepatitis B, a really useful vaccination, but only in people who are involved in exposure-prone procedures. That means generally procedures where there's blood involved and cutting or suturing or whatever. And but extending that to everyone, and particularly into the care home sector, with a very diverse workforce, largely private sector employed, is going to be very controversial. And then the other issue is the issue of vaccinating children, and people are taking different positions on that as well. The arguments about children don't suffer badly from the virus, though not enough people talk about the level of long COVID in children. And they say, well, we don't know the vaccine is safe in children, and we shouldn't do it, and so on, and it's of no benefit to the children. But you need to think very broadly about the effect of vaccination across the whole population, and there are some vaccines that we do give to children which are not for their benefit at all, therefore our general societal benefit of getting rid of dangerous infections. And I do worry about some of this kind of live with COVID nonsense. That there is no other extremely dangerous infectious agent that we would ever dream of saying, oh, let's live with, such and such a thing. You wouldn't do that. You just wouldn't do that. You would do everything you could to protect people from getting dangerous and potentially fatal infection.
But I think, so it's interesting you bring up the point of compulsory vaccination, and that can, I've heard arguments that make a lot of sense to me that say that kind of backfires. You don't get better vaccination coverage when you make it compulsory, because what happens is the people who were very enthusiastic about getting vaccination were enthusiastic anyway. So the making it compulsory or not changes nothing for those people. And who it potentially changes things for are the people who had some question marks and who were wondering. And maybe when you make it compulsory, it perhaps reinforces a feeling that this is something that is being pushed on them, and then they become more resistant or hesitant to get vaccinated. So even though the intention might be to increase the vaccination coverage, it backfires. So it's not necessarily good policy in just about any way. It doesn't achieve the goal, and it alienates people.
Yes, and it's going to be a very difficult debate. And on the other hand, you can point to the outbreaks that have taken place in hospital, where it's clearly been brought in by staff, and as a result, in quite a number of deaths, including in one or two of the hospitals in Northern Ireland. And if I was going in to have chemotherapy or something that would really reduce my immune system's response, I would think it was a kind of duty of care thing that all of the staff who were looking after me while I was in that vulnerable position were doing everything they could, including being vaccinated, to try and stop me dying because of my hospital treatment, really, from an infectious, dying from an infectious disease picked up in the hospital environment. That would be terrible, I think. So there is a real debate to be had about that.
So that case is very clear. Yeah, you wouldn't at all want that. And I think when you have extremely vulnerable people, as we know, in certain vulnerable people, they are less likely to respond to the vaccination,
Yes.
people who are immunosuppressed or something. So they do rely on the people around them being protected. So you mentioned there about Boris Johnson's inaction. I saw some video or some news clips where it seemed like on different days and weeks, as the days were going by, he kept just saying, "Oh, I see no evidence for this. I see no evidence for this, and or no evidence that makes me think, we need to worry about what we know as the Delta variant." And it was so frustrating watching this. And I felt like saying, well, just because you can't see it, maybe, talk to somebody else or open your eyes or something. But it seemed like such an easy way to avoid, just avoid taking any action. Is there a sense that there was a huge missed opportunity then in the UK, in the sense that Independent SAGE and indeed SAGE and Public Health England were all warning about this Delta variant for quite a few weeks now? I'm not sure exactly how long it's been that we've been publicly, loudly saying this is a dangerous variant. So they first said it's potentially more transmissible. The evidence kept mounting. They explained how, with the level of vaccination that you have already in the UK, which is one of the more advanced levels of vaccination, even with that level of vaccination, you have enough unvaccinated people that there could be an extraordinary surge that could again overwhelm the hospital system. Yet it took weeks before they did anything about this. Is there a sense that there's this huge frustration with Boris Johnson, and that, the delay now in the Freedom Day reopening is down to inaction?
Well, dither and delay has been the sort of base response, really, of the government to things. But I think there's starting to be a real intolerance of that, and across the spectrum in a large population, as some of the thinking behind it emerges. I mean, one of the most revealing things that's happened in the UK in the last week or so was Matt Hancock, who's the Secretary of State for Health, appeared before a Commons committee to discuss the government's response. And he was asked about support for people isolating, because I don't know if you know, but there isn't really a proper find, test, trace, isolate and support system. And one of the things that's been heavily criticised is the absence of support for people who are supposed to self-isolate. And that is a really major issue. And we know that a lot of people don't self-isolate when they really should be self-isolating. And the major driver for that would appear to be that they may lose their job, or if they may not have a job, they may be self-employed on what we call a 0 hours contract. So they're on a sort of a call-off contract. And if they're not available, they get nothing. And there's been such limited support for them that economic driver has been really important. And some international comparisons have shown that the UK's support for people who are off on health grounds, not able to work on health grounds, has been really, really poor compared almost to anywhere else, really. And he was asked about that at the committee, why the government didn't do that. And he said it was because they'd had discussions about it, and the view was expressed that people would game the system, that they would either become deliberately infected with the virus in order to get money from the state if it was too generous, or that they would falsify test results in order to get money from the state, and they weren't going to have that. And as a result, we ended up with one of the key failures of the system. And it's such. Firstly, it's insulting to the vast majority of people who are not like that and are not dishonest and wouldn't dream of doing such a thing. And secondly, it just destroys the effectiveness of the system. And I think there are other things, such as, people will find this very strange when it's not much talked about, but the UK still doesn't test, although they've got huge testing capacity now, still doesn't test the people who are at highest risk of being infected. So the people at highest risk of being infected are those who've been in close contact with someone who has just tested positive, really. And so those close contacts should all be tested, and they're not. What happens in England is that they're told to self-isolate and only come for testing if they develop symptoms. So we know people don't self-isolate, and economic drivers is one of those things, and they're not being tested. So you miss out all of those people who are asymptomatic and become infectious and go on infecting. So, and that's completely against the guidance of WHO, the European Centre for Disease Prevention and Control, even CDC in Atlanta. And so there are these big gaping holes in the UK government's response, of which, as you correctly said, their open borders policy is absolutely one. But there are other really quite substantial chasms in their response as well, which will undoubtedly be revealed and explored, and the subject of much criticism in the days and months to come.
Yeah, I mean, you're getting onto like what we titled this session Vaccines Plus, because it's vaccines plus other things that are going to help us get out of this situation. So, as we've already said, the vaccines are extremely effective. We're very, very lucky to have them at our disposal, but we shouldn't squander the opportunity they give us. They give us this amazing opportunity to get things really under control and to have a pretty normal quality of life again, in the short term, as we wait for this longer term project, as you've described it, perhaps over 2 years, which is, getting the vaccines really to everybody in the world. And so when we talk about the plus, I mean, you've mentioned a few things there. I'm going to perhaps bring in other people on the panel on this as well. But, you mentioned that the test, trace, isolate has not been properly resourced and has not been sufficiently developed. We as the case numbers go down, we should be casting our net wider. We should keep our contact tracers fully busy all the time. They should, so they shouldn't have less work to do when there's fewer cases. They should be casting that net wider and getting the contacts and the contacts of the contacts, rather than going, that should be something we're doing. You mentioned supported isolation. You mentioned border controls as well. And, it's quite plain the Delta variant came to the UK through travel, and it's arrived in Ireland through travel and insufficient border checks and controls. And even when we have a situation where people are required to have tests and we have quarantine from certain countries, these things, the testing is plainly not sufficient, because if it was sufficient, these cases would not have arrived and spread at all here. So we're lucky that it hasn't got bad here yet in terms of the Delta variant. But, we're at the point where in a few weeks' time, our government is talking about opening indoor dining and indoor hospitality without requiring any ventilation standards or any other standards. So they're just allowing some distancing of tables, but this becomes some kind of fairy tale epidemiology. I don't know what I don't know what the basis for this is. And so it's, they haven't put in place these things. And so we are squandering, or potentially squandering, this good situation we're in. We see our cases coming down. We know our vaccination rates are going up all the time. We know the vaccines are really, really effective once they are delivered. They're not effective when they're sitting in the freezer. They're effective when they're in my arm and after I've waited the correct amount of time, then I'm protected. So saying the vaccines work is not enough, so we have to give them the chance to work. And so I think this is where we need to really learn lessons from what's happening in the UK, and we have to, get things right here in Ireland as well. Maybe I could bring in Tomás here, because I think, Tomás, you were talking about there's a comparison that has been made. So Rachel Lavin had a really great piece in the Sunday Business Post this weekend just gone. And I think we were talking about, it was a really good article where she did a really sensible, clever analysis of comparing different countries with comparably high level of vaccination, but different other things. So the plus is lacking. It's a plus or minus in some of these countries. And you see different outcomes. And I think that's worth pointing out. Maybe you could mention that for us, Tomás.
Yeah, I think that this particular article by Rachel Lavin at the Business Post was very prescient in how we need to be thinking about our own pandemic strategy in Ireland as we're coming out of the summer. Obviously, right now, we're dealing with the race to get as much vaccination done as possible in Ireland, and we're concerned with the risk of a fourth wave, which we're not doing enough to prevent, and we're concerned with what the Delta variant may do to significantly increase that risk. But moving away from the short term, looking at the medium term, when we do have the majority of the Irish population vaccinated, we need to start looking at what that really looks like. What does that look like epidemiologically? And what does that look like for us living our lives on a day-to-day basis? And it's very informative to compare the countries that have been really successful in vaccination thus far. Israel is obviously one of the world leaders in vaccination, and they have essentially gotten effectively to an elimination state where they're almost zero COVID, depending on what your standard for zero COVID is. It's also worth noting that after Israel got to 60% vaccination of the entire population, it took a lot of work and time to get even significantly above that. And they're still having difficulty in getting the kind of buy-in that we would like to see here in Ireland. Despite that problem, because of how they're managing local public health, because of how they manage schools, and because of how, very importantly, they're managing international travel, they are getting the maximum benefits of the vaccination program there, both in terms of health and in terms of the economy. In contrast, when you look at the United Kingdom, notwithstanding the issue of the Delta variant itself, you're seeing very large case numbers still comparatively, and a risk of them increasing as the UK is opening up. Similarly, in the United States, as we're seeing restrictions being relaxed at an accelerated rate in a lot of places, you're going to still see a large risk of infection. And how this affects life is very significant because, first of all, it affects how a responsible government is going to have to keep low-level restrictions to a certain extent on the population. But more importantly than that, it's going to affect the behavior of individual people. A lot of the voices that we hear in the media are saying they don't want restrictions for a particular sector of the economy. What they're really saying is, we don't want restrictions, but we also want everyone to behave like it's 2019. And that's just not how people behave. As long as there's virus in the community, as long as people are at risk, as people see more and more that we don't really know how long immunity is going to last, as people see that the vaccines are not 100% efficacious, there's still a risk of disease, of hospitalization, of long COVID, and of new variants. People's behavior will not go entirely back to normal. And of course, people have learned new habits throughout the last year and a half on top of that. So what we need to look at is, economically and socially, who is doing best out of the highly vaccinated countries. And what you will see is that Israel, the UK, the US, Canada, and Chile all give very different stories for how it can be to live in a country with high vaccination. And the thing is that in Ireland, we have a particular advantage here. Despite the fact that we're on top of the fact of being an island, we also have the highest vaccine enthusiasm in Europe, or amongst the highest vaccine enthusiasm in Europe. We can get to a very high level of vaccination in the population, including children after vaccines for children become approved and we have confidence in them. So we are in a unique position. We're in a unique position to use vaccination possibly more effectively than almost any other Western country to really drive cases down and keep them down. Because as long as the R number is below 1, then getting to elimination is a mathematical inevitability. And if we use vaccines to do that and a proper way of managing travel, then we can have an epidemiological success story to be proud of in Ireland.
Yeah, it's great. I mean, and it is encouraging. And as Gabriel mentioned earlier, I mean, we know much more now about the vaccines in terms of how they can actually prevent infection and prevent transmission. So the vaccines will be really, really effective in driving down the R number. And then while we are waiting to get everybody vaccinated, because, we said the government policy is effectively wait for the vaccinations. That's what we're doing. At least that's what we ought to be doing. And instead of having this race against the vaccines versus the virus, we should be cheating in that race. We should be like putting impediments and making the virus slower so that we can win that race more easily and more comfortably. It is absolutely the only ethical time to cheat, I think. So cheat in the race against the virus. I think Professor Jerry Clean wanted to come in here as well.
Yeah, thanks very much, Aoife. I think what Tomas has said there is really, it's something we should pay attention to, because I'm just talking about the roles of the plus. The first thing is it gets you there faster. That's the first thing. It's just, if you're just, kind of less haste, more speed. If you're just a bit more patient with sustaining your non-pharmaceutical interventions, you get there faster and then it's over. So the second point is the decisiveness of that end point. And I was just thinking, we just had our slice of the outdoor summer this weekend. We went down to Clonakilty, we pitched a tent, and we sat out and we watched the sun going down over Clonakilty Bay. And for the first time in a long time, we didn't have to watch the sun go down and plan to get the kids into their trousers or close the tent to make sure the mosquitoes didn't get in and all that kind of stuff. Now, we've had holidays in situations that are almost malaria-free before on Zanzibar. But still, we had to go through all that routine. We had to go through, it just becomes part of your life. You accept these habits. You get used to the sun goes down quick, trousers on, kids, roll down the sleeves. You get used to the regular rapid tests, the dozens of negative tests, but one or two positive ones. You get used to the idea that your kid might go to hospital, but he or she will be okay, because you'll treat them and all that kind of stuff, but you just don't want it. So it becomes a part of your life. But to have that gone and to just relax and let the sun go down and watch it with the kids in their shorts and a bottle of wine, with my darling wife, we never knew how much all those inbuilt habits were weighing on us until they were gone. And so that's the difference between allowing endemicity to persist at a low level and elimination. And also the peace of mind that we would have, that we would know, even if the virus pulls off some magical evolutionary trick somewhere on the planet, quite possibly next door, where we have kind of lots of partial vaccination, then we know our public health teams can cope with this. If you have an outbreak of something really nasty, it's one outbreak. You see it. There's no background of other outbreaks ongoing. And it's like the teams in Australia. Once they saw their first outbreak of Alpha, they noticed the difference immediately and changed their procedures different immediately because it was the only variant they were dealing with. The same for Delta and Kappa. And so once we get to that decisive endpoint, all our lifestyles change and we can all sleep better at night. And just having been through it, I highly recommend it to everybody. Endemicity is an indecisive endpoint. It's asking for trouble. And for those of us who think we can live with this, it's not so much fun.
No. And you mentioned there rapid testing, and this has been talked about a lot. I think it's taken on a rather strange place in the debate. In my opinion, it seems that it seems to have polarized a lot of people in terms of antigen testing. It's either going to fix everything or fix nothing. And I don't think either of those is true, that we should be using every tool at our disposal. But maybe, I know, Jerry, you have quite a bit of experience in the use of antigen tests. So maybe you could give your perspective on the position, the place they hold in a strategy of vaccines plus. We're trying to have as many pluses as possible that are convenient and easy and effective. So where would you see the antigen testing there?
Sure, Aoife. Yeah, no, they're really easy to use, to do one test. The hard part is to use them in a disciplined way over the long term, so particularly after you've done a few of them and they've all been negative. Or see, now I'm making the slip myself. I say negative, whereas actually it means, not determined. So kind of retaining the discipline to say, okay, I don't see a second stripe here. But that doesn't mean my daughter doesn't have malaria. In fact, in one case, or COVID or whatever, I've thrown the test into the bin, and it's only when it hit the bin and I caught it in a different light that I saw this very faint stripe. Got her up to the restaurant, got some eggs and tablets into her. She collapsed for the rest of the day, but by the nighttime, she was back on my lap chatting away. So all is fine. But all is fine because of the light, the shaft of light that hit the kit when it was at the bottom of the bin.
Yeah.
So the discipline required to keep testing when you get so many, not detected results, and then to remember that this not determined, or not detected, that's what it is. You're not 100% sure that you're fine. It's just really tricky in practice. So, and then our experience outside of our family on a professional basis with population level testing, where we actually went to, sent people around to everybody's door, knocked on their door every month, is that everybody gets tired of it. And so you get a small number of enthusiasts who get tested every month, and their health outcomes improve enormously. But most people really only say yes when they feel a little bit sick. And, and that's where the walk-in test centers for me come in. So for me, they're very useful. There are lots of logical applications, and a lot of them are already happening. Let's not forget that lots of workplaces are already doing these, but for that, they need support from our public health teams. And there's only so much that our public health teams can cope with. So, it's not that we're not using rapid tests. It's just that they're not a magic bullet. And, they just don't stop you from getting infected in the first place. So they're not a substitute for not going to the barbecue. It's not a reason to not have those kind of indisciplined, messy, fun pints somewhere that you shouldn't be. It's not a substitute for all that. And it's tricky. Even as an expert, it's really tricky to look at that test kit and go, what does this mean? I struggled with it. And the more the kind of less comfortable you become.
Yeah, I heard it described. I thought it was a useful way of describing it as it's something to put into your equation when you're weighing up. What's the probability that I might have COVID, or I might be carrying it and potentially transmitting it. So if you're in a part of the world or a part of the country that has a really high caseload, then high case number, then it doesn't change the probabilities that much for you. So you got an undetected, but that's good. But you still can't be hyper confident because there's all of these other reasons that you might have been exposed. But if you're in a part of the country where you have really low case numbers, then even without the test, you can be quite confident that, or a part of the world, you can be quite confident. So it adds into the equation. I think it needs to be considered in that way. And, so we can use it to help find cases. We can use it to help find, and that will help us reduce transmission. But I think there's been certain discourse that is implying it can solve everything on its own. And I think nothing solves everything on its own. And that's something that we ought to be aware of at this point. We use all of the tools at our disposal, and in combination, they're really going to be helpful. So there's questions about reopening indoor hospitality. And of course, this is something that's on the agenda in a few weeks' time in Ireland, despite the fact that they have not placed any criteria on what this should be like. And I think we have an interesting possibility to learn from what's happened in Northern Ireland. And I think Andrew Kunzman can perhaps give us an insight there, because in Northern Ireland, they have opened indoor hospitality a few weeks ago, and of course, with a high level of vaccination in the population. So Andrew, what can you tell us about the picture there?
Yeah, so I think when Northern Ireland did reopen its indoor sector, I think a lot of people, not just people within ISAG, but people like Professor Alton Power and some of the virologists felt that it was a few weeks too early for where we were along the vaccine rollout. And you still had the very sociable people who are perhaps younger and who were unvaccinated, who were keen to go out after a long time under restrictions and who will take any opportunity to see their friends. Unfortunately, that means that there's a large proportion of the people in a sector that haven't been offered a vaccine yet. So I think it's about avoiding having a large part of the sociable population unvaccinated when you reopen indoor hospitality. One of the examples from Israel that you see that overall their level of vaccination wasn't too different from the UK's, but the difference was that they had vaccinated a lot more of their younger population. They had vaccinated some of their people about to take exams. They'd vaccinated some of the younger people who were serving in the military. And I think that's the important metric that you want, is how many of the 18 to 30-year-olds have been vaccinated. And only when there's a reasonable proportion of those vaccinated could you suggest that it's likely to be safe, because you see the cases in Northern Ireland, it's rising in those unvaccinated populations. And that means that there's a lot of people getting sick a few weeks before they would be getting their vaccine. And that would just be a kicker for me. If I was to get sick a week before my vaccine, I'd be absolutely gutted, because it just shouldn't be that way. So protecting those first and then reopening seems like a much more sensible idea. And I don't think that Ireland will be in that position where enough young people are vaccinated by the time they plan to reopen indoor dining. And I think the Wales example is particularly scary, because they have vaccinated about 60% of young people with one dose, and it's still shooting up quite high. So I think it's something to bear in mind when doing that.
Yeah, I mean, we know that indoor settings are the riskiest, and it's down to ventilation. The difference between indoor and outdoor is free ventilation, and so the air being able to move freely. And I have not seen proper standards articulated for reopening of indoor dining. It just seems to be, there don't seem to be ventilation standards at all. It just seems to have been mentioned as a desirable, but suddenly various restaurant and pub owners are supposed to know what good ventilation is without proper guidance. And I would take the view that it should be of the same status as the hygiene standards in the kitchen. You want to go into a place and know that it's safe, not because you've personally inspected it, but because there are standards that they must meet in order to be open. And that work doesn't appear to have been done, even though there was plenty of time to do that work. And with regard to vaccination, we haven't even opened the vaccine portal for our population in their 30s yet. So we're not at the 20s and the 18s plus. So that's a while off for us. But we're just past the hour now. So I think we should finish shortly. But I would like to go back to Gabriel Scally just one more time, just to ask you, what should we be learning from the UK? What should our Irish Vaccines Plus strategy be? How do we get the best advantage from these wonderful vaccines, have the best chance at an enjoyable domestic summer, and also, I would add, safeguard the return to the next academic year, which is something I have on my mind as someone who works in a university, and I've seen our students have 2 now disrupted years, and I know our secondary school students have had 2 disrupted years. Somebody entering their junior cert year has not yet had a full year of secondary school. That's awful. And we have students in a 4-year course, of which 2 years have been severely disrupted. So I think it's not only riding out the summer, it's not leaving a mess for the autumn and beyond. So Gabriel, what would you say the Vaccines Plus strategy ought to be?
Well, I think it should be a very busy time for us. I think there will be a great temptation for everyone to relax, and who can blame them after this year and a bit that we've had? It's been exhausting for everyone. But there is work to be done to make sure we can continue to enjoy relative freedom from this dangerous virus, and make sure it doesn't cause us problems. So I think we need to concentrate on, of course, the vaccination, and particularly making sure that it reaches all areas of society, and not be afraid to put in special arrangements in places where we know that there's going to be difficulty maybe in getting the vaccine levels up to as high as they should be. And those tend to be some of our most deprived communities, and putting extra resources in there. at the back of it all is the strength of the public health resource in the country. And that's something I've been talking about in the Republic of Ireland for 20 years. And one of the, it's a strange thing to say, but apart from vaccination, one of my highlights, I think, of the whole COVID problem has been the announcement by the Minister of Health, Stephen Donnelly, of finally getting the status that was needed really for the public health doctors, and the very clear commitment to appointing a lot of new consultants in public health. Fantastic. And that needs to be followed up with real empowerment of the local directors of public health, who should become the best. One of the characteristics of, in the 19th century, of the great successful public health performance at that time in the face of epidemics of different sorts like cholera and typhoid and so on, was that the local director of public health, or the local medical officer of health, as they were known in Britain and Ireland, was one of the best known people in their local communities. And I think local directors of public health need to be empowered and pushed forward, and pushed really to take a leadership locally. Now, some of the things you touched on, Aoife, are perfectly right. The absence of any real effort on ventilation. We seem to have forgotten all about those lessons of the past, and other places do it really differently. The US actually has never, and particularly those cities that were hardest hit by the Spanish flu, by that 100 years ago, have never lost their understanding of the importance of ventilation. And it's back with us in spades, and and it's a technical issue largely, and we should be turning to our engineering community, who haven't been fully engaged to date, I think, in the pandemic response, as to how they can engineer us to have healthy places to live in and work in the months that come. And also, of course, energy efficient as well, because we mustn't throw away energy efficiency and forget about climate change and the importance of that. And of course, the importance of energy bills for people as well. So there's a whole range of stuff that needs to happen. And neither should we forget some of the other advantages. I mean, I know it's a minor thing, but we've all benefited from not having repeated colds and other viral infections, upper respiratory tract infections, which can take a big toll on children's education as well as parental responsibilities and looking after them, all of that stuff. And we haven't seen that. And that's because of our kind of enforced hygiene arrangements. So we should probably look at things like not just the ventilation, but the hand washing facilities in all of our public institutions. I mean, I grew up and practiced public health in an era when we were busy taking out hand basins and the soap and water approaches to public health, because we thought infectious diseases was really not important anymore, and we didn't need all of these things. Well, we do need them. And all of this work, all of this really basic public health work, stronger teams, more attention to basic public health and sanitary issues like ventilation, like cleanliness and so on, will pay us benefits, because not only could COVID-19 make a resurgence, hopefully it won't, but it could do, but it's unlikely to be another 100 years before the next pandemic. It's not likely to be, it may not be 10 years, it may not be 1 year. Something else could emerge and cause exactly the same problems. So why not take this opportunity, it's an overused phrase, but to build back better for public health, for all our health and all our sakes. So that's what I would be doing over this next few months.
Thank you, Gabriel. I think, there's so much in there, that our public health, in Ireland, maybe we have this privileged position in the sense that I'm sure in the UK, they wish they could roll back the clock a few weeks and maybe do a few things differently. And we are in that position. We're, in a sense, this few weeks behind. We can see what's happening in England and Scotland and Wales, and we can try to avoid that. But yes, so we have the vaccine rollout that is going really well. We are really lucky with a population that's very enthusiastic about their vaccines and they're taking them. We need to resource our public health doctors properly. We need to keep doing that so that our contact tracers are kept busy, expanding the net that they are tracing so that we catch every case and the secondary cases that are linked. We want to make sure that our every premises is properly ventilated, and these become standards for the future, not just for a few weeks. We want good ventilation all the time. And, we also should keep like a few things like you mentioned, like never make it normal to go to work sick ever again. You are not a hero for turning up to work sick, sniffling and coughing. You're actually, probably, not only not that productive yourself, but you're going to make everybody else around you unproductive a few days later. So there's things in the short term, like this summer, we need to protect our situation, that we have our cases coming down, our vaccination rates going up all the time, and we should not jeopardize that. We have the chance of having an enjoyable summer and having a safe and secure return to the academic year, and we should not jeopardize that. We use the vaccines plus the other tools at our disposal. I think maybe just a quick last word to Jerry Colleen, who wanted to say something about vigilance.
Thanks, Aoife. I just want to express my concern about the use in the UK and here in Ireland of the term vigilant. Vigilant implies a reactionary response, which is okay for diseases that you can cure. Where you can shove the tablets down your throat and you're going to be okay at an individual level. It's not very useful for COVID because there isn't a cure. You've just got to ride it out and go through whatever care you need to go through. And then at a national level, that's basically kind of says we're going to react to the problem when it happens, because you can see it, which means you're really reacting. And as we know with COVID, that's often too late. And these things do get out of control far too fast, particularly when we still have high background rates of 200 cases a day. Outbreaks of something unpleasant like Delta could get quite large. By the time you pick up all those cases, get some of them sequenced, the news comes back. How do you know that's not spread across 6 HSE regions, as happened with one outbreak linked to a single flight coming from the United States? So, a reactive strategy is asking for trouble. There's no place for vigilance. We need preemptive, proactive strategies that deal with things that we can see coming down the track. And to simply accept that the Delta variant is going to become dominant here, for me, is an unacceptable level of defeatism and an abdication of responsibility. And I, as a citizen, I don't accept it.
Yeah, I think evasive action is the name of the game here. And I think, like you say there, Jerry, if we just say it's an inevitability that the Delta variant will arrive here and become dominant, does that imply we've learned nothing over the last 15 months about how to deal with the pandemic? Because as Gabriel said, this is not going to be the last pandemic. And one of the things we definitely need is that we learn better how to respond quickly and to not let this happen the way it happened. If every country in the world responded as quickly as the countries in the Asia Pacific area responded, we would already be talking about this in the past tense, I believe. It would have been probably eradicated. This moment passed, people didn't react, but we need to do that next time when there is a next time, because unfortunately we can probably expect that there will be. Okay, so I think that's it for today. And so thank you very much to everybody who has joined us both in Zoom and through the various streaming. Thank you especially to James Merrick and to Gabriel Scally for wonderful contributions today. I think it's been really instructive, really informative, to see the current situation in Ireland, the worldwide situation, and also then to look at, where things are going in the UK and, what steps we can take to avoid that happening here as well, so that we can protect our situation that is improving day by day. So thank you very much, everybody, and see you next time.